Hi, listeners.
Hello. Welcome to the Med Insights Unleashed podcast
With your hosts,
Z
and John.
How's it going, John?
It's going really well.
We have in the studio today, it's wonderful. We have a Canadian physician. Yay! I'm biased, John. Christine Simmons is with us in the recording studio, in the virtual recording studio. I've known Christine for a number of years, again, through my past life in pharma. Christine, thank you very much on behalf of Med Insights Unleashed for being with us today. And you're going to walk us through the very important topic of breast cancer.
Just a small topic, right? Just a tiny little topic.
Small. Before we leap into it, can I just ask you to introduce yourself, and so that the listeners know who you are and everything about you, almost everything.
Oh, thank you so much, Sarah and John. It's really a pleasure to be here. Thank you to Med Insights for inviting me. As you said, my name's Christine Simmons. I'm a Canadian, originally from Toronto area, and now hailing from BC, Vancouver, British Columbia. I'm a medical oncologist. I specialize in treating breast cancer and did fellowship training in breast cancer. I also specialize in sarcoma, so I have that kind of side to me as well. The disease sites that have lots and lots of evidence behind them in terms of breast cancer, and then sarcoma, where we have a rather small, sometimes completely lacking amount of evidence, which I think allows me to provide a bit more of a pragmatic perspective to some of the data and some of the information that's out there. Not to talk too much about myself, the other things that I do teach a lot. So I love teaching. I've had the privilege to be involved in medical school teaching at UBC. And I'm currently the program director for the residency training program, in charge of helping to educate more medical oncologists for Canada, which I'm super excited about. And really, it is an honor and a privilege and a duty as a physician to be involved in educating the next generation. And then I have this other little role where I'm the chair of all of the provincial tumor groups for British Columbia. And so we're working toward improving pathways of care for all of cancer in British Columbia. And I love that role as well. So that's who I am. And absolutely pleased to be here and to talk about this tiny little topic of breast cancer.
Well, thank you. You're very busy. Lots of hats that you're wearing, and you're a mom, and you're a researcher, and so thank you.
Well, it is. It's amazing what you can accomplish when you love what you're doing. I always say that we're moving in the right direction and we're doing what is true to ourselves when you look back and it never felt like work. I can say, but a significant proportion of what I do doesn't feel like work, which is great.
That's how it's supposed to be.
So, Christine, you mentioned that breast cancer is integral tumor type globally. Not exactly as small as you said, but maybe
no, it's absolutely no. Breast cancer is not a small topic at all. It is a huge issue, provincially, nationally, globally. As you said, the numbers of people who are diagnosed with breast cancer annually are staggering. And I will say, globally in this post-pandemic world, we did see globally the screening for breast cancer during the pandemic shut down for 6 months. I'm pretty sure everywhere on planet Earth, because I did look into that and research that a little bit at one point. And we know that adherence to screening in Canada, in the US, in the UK, in most places around the world, I would say, typically previously we were only getting about 60% of all people eligible for screening actually participating in screening programs. And in the post-pandemic world, that number has absolutely dropped. And what that has led to is that we are seeing people diagnosed with breast cancer coming in with a higher stage of disease, with a situation where we are often needing to offer more aggressive treatments than we were before. I think that the statistic that I've seen recently is that in BC, I think we're giving about 10% more chemotherapy than we estimated we would be giving at this point in time. across the board. That kind of, it gives you a bit of a sense. 10% doesn't sound like a lot, but when you're talking about big numbers of people, it's actually huge. And definitely, if there's any message that listeners can achieve from listening to you here today, please return to your screening programs as well.
Can I ask a question before we jump straight into other topics around breast cancer and have you walk us kind of through the pathway? Well, you mentioned a number, 60% was kind of the number that you mentioned pre-pandemic screening. Help me understand, because I know there's been high number of patients being diagnosed, a lot of research and development, R&D monies all go into breast cancer. So why is that number not higher? Shouldn't it be higher at 90% versus 60%? Help me understand pre-pandemic and then post-pandemic. We'll talk about that.
I think that, this does truly jump into that pre-diagnosis phase of the pathway treatment for breast cancer. Why are the numbers only 60% at this point in time globally? I think previously in the 80s and the 90s, there was a big push, a big advertising campaign in terms of getting out there and screening. I think at its peak, I think screening probably hit maybe around 75%. To your point of why isn't it 90%? Why isn't it higher? There's so many things that go into that. Access to screening programs, being able to be aware of the importance of screening, of what the current screening guidelines are and who is eligible. And then it is, to be quite honest, it is a test a mammogram is not a super comfy thing to go through, right? It is not comfortable. And I think that there is still a hesitancy to return to healthcare. I think there is still globally a concern about exposure when you're entering a healthcare facility. There is a huge burden, and I don't like to use the word burden, but there is a lot of strain in the healthcare profession from a human healthcare resource perspective. The number of people who are trained to be mammography techs, the number of people who are trained to be able to do ultrasounds as well. Those are two different certificates of training that are required, right? And having these highly skilled people in the workforce is so very critical. And I know in British Columbia, I think we're in the negative 20% numbers in terms of workforce for technicians in terms of completing these scans. And you layer in the radiologists that need to read the scans. I don't mean to paint an overly bleak picture, but there is strain, quite frankly, on the healthcare system. That is not a good excuse.
Right.
It's not a good reason for there to be lack of screening. But I think that if there's anything that we can do to empower people out there listening who may be eligible for mammograms, if you have a personal family history of breast cancer in the family, someone who's directly related to you, like your mom or your sister or your daughter or first degree relative like that, you are eligible starting at age 40. If you are someone who does carry a genetic predisposition to developing breast cancer, that also is someone who would be eligible starting at age 40 for screening mammograms in Canada. And I believe those guidelines are very similar around the world.
You bring up genetic predisposition for patients. Can you highlight a little bit of knowledge on this topic?
Absolutely. Yeah, that is an important question. The genetic predisposition to cancer, to breast cancer, previously the statistic, I believe, was about 5% of all people who develop breast cancer developed it because they inherited a gene from mom or dad that increased their risk of developing breast cancer. I think that statistics is actually a low estimate at this point in time. In the past, we had previously discovered the BRCA1 and BRCA2 genes. These are two genes that actually work to help, when they're working correctly, they help to correct any mistakes that are copied into DNA when our cells are dividing. And these BRCA1 and BRCA2, they're what's called tumor suppressor genes. They actually work to decrease the risk of mistakes being perpetuated when cells are copying themselves and dividing. And all cancer, in any type of cancer you have, all cancer ultimately comes down to accumulation of mistakes in the DNA that are copied in even just one cell. And once that cell has developed enough mistakes to cause it to become a cancer cell, that is perpetuated and continues on. Several more genes, PALB2, PALB2, CHEK2, ETM, just to name a few. And there's some really great references that came out just a few years ago in New England Journal of Medicine, and a lovely schematic that I'd be happy to share with you as a reference link later. If there's some super keen learners that or listeners, sorry, I call listeners learners. I hope that's okay.
We're all learners.
The aspect of genetic predisposition. That means that you are at higher risk of developing breast cancer in your lifetime if you have inherited one of these genes from mom or dad. And the likelihood, the risk that you're at is different depending on which gene you inherited, right? So BRCA1, BRCA2, those are still the highest risk in the range of the other genes have a slightly lower lifetime risk associated with them. And there may be other additional cancers that you're at risk for, not just breast cancer, if you've inherited one of those genes. The genetic testing, how you determine if you do possess one of these genes, that's an important piece of this. And this is, tested. It can be tested through blood, and typically these tests are offered to people who have developed. In my world, I'm just sort of speaking from a breast cancer doctor perspective, so please keep that in mind, listeners. I will fully confess, for the most part, anytime I'm seeing a human being who has breast cancer, I am now asking myself, why am I not offering this person genetic testing to determine if they inherited this risk? And if they have inherited this risk of developing breast cancer, then the rest of their blood relatives would also be offered testing to determine if they also carried this gene. It's not 100%, right? If you have a gene that predisposes you to developing cancer, breast cancer, and then you are to have a baby, the likelihood of you passing on that gene to your baby is a 50-50 chance, right? Because you have two copies of every gene. So you have one functional BRCA gene and one that's changed or mutated or broken, not working right? And so the chance of you passing on that broken gene to your baby is a 50-50 chance. Does that make sense?
Yes.
What surprised me is that the father can pass it on, which it's not necessarily coming from mother to daughter, and the father can actually pass it on. I'm not sure how many people know that. And if they are being tested, as you said, the whole family should be tested.
Exactly. It's not just women in the family to be tested, it's men as well. Absolutely. 1 in 100 people who develop breast cancer are men. So men have breast tissue, men can develop breast cancer. If there are male listeners out there and there is something, if you do feel a lump in your chest wall or in your breast tissue, please reach out to your healthcare provider. You can have a mammogram as well. Men can get mammograms, and it is important to be checked for that. But yes, it is something that's passed on, that men can inherit and can pass on to their children too.
So the question I had was, when you mentioned around the genetic testing and, when patients come to your office, you would love to ideally test all the patients. So at what stage? Because by the time a patient comes to you, you're a medical oncologist, that means that they've passed that screening process, right? So they've had the mammography. What's the ideal time to have the genetic testing done? That's my first question. My second question is, how costly is this testing? And what should patients then go away with from this conversation that we're having?
I'm going to answer the second one first. So, how costly is this testing? People who do have a likelihood or a higher than 5% likelihood of having a genetic predisposition to breast cancer as the reason for why they developed it, those people are offered, as I said, should be offered testing covered by the Canadian healthcare system. So for those people who do fit into that category, the cost is or should be $0. Not everyone fits into that category. There is the ability to do private pay testing, to reach out to a lab, and Invita is one of them. There are others. We can probably ensure that those resources are available to your listener as well, in whatever way, shape, or form you pass on that information. But yeah, so the cost privately, I think, is in the range of around $200 to $300 US to undergo this test. For many people, it is a bit of an investment, but, I would argue an appropriate one. You asked, what is the ideal time for this test to happen? I mean, okay, are we talking magic wand world here? I'm going to take it as, magic wand world. What would be the ideal time for genetic testing to be done? Here is an opportunity for us to identify and be able to act in a way that is preventative in terms of decreasing the chances of that person ever getting breast cancer, right? That is, before you have breast cancer, that's the ideal time. Right. To have that testing done, because you could argue that, once you've developed the condition, we have clearly missed the boat in terms of preventing that from happening for you. However, hopefully we can prevent that from happening to other people who are related to you. And hopefully we can prevent you from developing a second breast cancer or another cancer that is related to that genetic predisposition. Sadly, the perfect time is actually long before you've even found a lump. And, knowing that you do have a genetic predisposition affords you opportunities to consider preventative measures. If we could just maybe spout on maybe a few preventative measures just to, in general, like move, everybody. If you're not listening to this podcast while you're taking a walk or jogging, hey, get up and do that right now, because moving, exercising, that is significantly helpful in terms of reducing all sorts of diseases, but cancer being a big one. So please get up off of the couch and move now. I'll wait. Are you up yet? Cool. Okay. Excellent. Wonderful. Now that you're up and walking and we're all moving here on the podcast, and hopefully you're getting outside and getting some nice fresh air in and out. Other things that you can do to decrease your risk of developing breast cancer: alcohol, limiting alcohol to five servings a week or less.
Five servings a week.
And a serving a week. Yeah, 5 servings a week. So glasses of wine, 5 glasses of wine a week or less, 5 pints of beer a week or less, or the, ounce volume of liquor, 5 or less a week, not every night, right? Other things, your diet, vegetables, fruits, whole foods, avoiding processed or over-processed foods. And there is some weak data, I will fully confess, about red meat, and perhaps decreasing the amount of red meat in the week to 1 or 2 days a week or less that you're consuming red meat. That may also be helpful in some weak data, right? I will fully confess, not strong. Other things that would be offered to someone who has a genetic predisposition. So we know that there's a 60% chance that in this person's lifetime, they might develop breast cancer. There are some surgical preventative strategies, right? Like undergoing a preventative mastectomy on both sides and reconstructive surgery. Again, that is basically, having an amputation of both breasts and reconstruction. That is very effective very effective in decreasing the risk of breast cancer developing in someone who has a high risk of developing breast cancer. Obviously, very dramatic procedure. And the other preventative measures, there is the ability to now prescribe tamoxifen at low dose, which is a medicine that was developed to treat breast cancer, but does have a benefit in terms of decreasing risk of breast cancer developing, cuts the risk by about 50% for people who are at higher risk of developing breast cancer. And there was a recent study in past years called the Baby Tam study, giving a low dose of tamoxifen on a daily basis for several years did help to decrease the risk of breast cancer in patients who were at higher risk. Those kinds of strategies, again, more intervention only really appropriate in people who are at higher genetic predisposition, but certainly other strategies that all of us can employ on a daily basis to decrease our risk of developing any kind of cancer, but especially breast cancer.
Yeah, I think that, the three key ones that you mentioned in terms of exercising every single day, moving about. I mean, this is why I love listening to podcasts, because when I'm hiking or running, that's what I do. Alcohol, 5 servings a week. Okay, so that's note to self. Sorry, that's listening to this podcast. And then diet, eating a healthy diet. It's harder these days because of increasing costs, but it's so important, right? The vegetable. Yeah. Decreasing the red meat.
The costs of living are incredibly challenging. Fish and alternatives often are a little bit cheaper than red meat. So that can help in some ways. Certainly vegetables are cheaper than red meat. That can help.
So you mentioned that tamoxifen is also used now. How would one make a decision between proactive double mastectomy versus tamoxifen? Is there a difference between the disease? How does that decision made? Because this is a tough decision for women.
Absolutely. Absolutely. No, it is a tough decision. And every decision is an individual decision. And the decision that an individual makes is the right decision for that individual, so long as that individual is the one that is making it. Right. And I view very much that my job as a medical oncologist, as an educator, is to ensure that the person who's sitting opposite me has all of the information that they need in order to make the decision that's right for them, because they are the expert in them. So talking through that, John, the double mastectomy, having a double mastectomy, how much does that decrease your risk? So if you are someone who has a genetic predisposition, so we know that there is a very high chance that at some point in your lifetime, you are going to develop breast cancer. Having a surgery to remove the tissue that is at risk, having that double mastectomy, reduces your risk from probably about a 60 or higher percent risk of developing breast cancer in your lifetime, reduces it down to about a 2% chance. All right. Mm-hmm. We can't give money back guarantees in life, in medicine. Anyone who tells you we reduce your risk to zero, I'm sorry. There is no money back guarantees in life. We don't know everything. We keep trying to learn, which is why this job is so cool, I think. But yeah, reducing from 60% down to 2%, that is pretty freaking amazing, and is why the choice or the option of double mastectomy and reconstruction is one that is chosen more commonly than chemo prevention, right? Which is what we call taking tamoxifen, or, the aromatase inhibitors, exemestane, letrozole, and anastrozole. Mm. They also have demonstrated significant decrease in risk as well. But in those situations, right, that taking the pill once a day for about 5 years, these pills in and of themselves do have some side effects, right? It's not just like taking a sugar pill. Decreases the risk. Again, if we start at that 60% level, takes you from that 60% lifetime risk probably down to 30%. So cuts that risk in half, but there is still a fair risk that in your lifetime, definitely higher than the population of people who don't carry that genetic predisposition, right? So yeah, there's a decrease in risk, but it's not all the way. And yeah, the side effects of the medication, it can cause hot flashes. It can cause some joint aches and pains. With tamoxifen, there is a very low but not zero risk of developing a thickening in the lining of the womb, endometrial thickening, that in a reported 1% of people can lead to endometrial cancer. So now you're taking a pill to prevent cancer, which will decrease your risk, cut your risk in half, but might slightly increase your risk of a different cancer. There is those trade-offs. These are important things for anyone to discuss with their healthcare provider. Everyone's risk is individual. Everyone's options are individual, and really important to understand what your baseline risk is to begin with before you're able to truly provide any value for you in terms of what these interventions will provide for you in terms of benefit. Does that make sense?
No, it does. And I think the other thing is the care that one needs to be surrounded by to actually support that patient is pivotal. And it takes a village, right?
Oh, absolutely. Absolutely.
Yeah.
And it makes me sad to know that often people will come to the clinic and have not realized that, or not know, or not feel that they have that team. But, from the moment anyone has diagnosis of breast cancer in this country, there is a whole team of us that are getting ready. We're all reviewing, we're all figuring out when is the right time for us to come into your life. When is the right time for us to come into play? Breast cancer in Canada is, I always say, it's a 3-member team approach, right? There will be a surgeon who is involved, a surgical team to help remove the cancer from your body. There will be a radiation team to offer any radiation treatment locally to decrease the risk of the cancer coming back where it was originally. And then there's the medical oncology team, which is the team that I play on. But we're all on the same team. But the medical oncology team provides you with medicine to decrease the risk of the breast cancer coming back. Sometimes the medicine is given before the surgery is done to improve the opportunities for your surgical options and decrease the risk of cancer being left behind when the operation is done. Jumped forward there to treatment. I hope that you all went on that leap with me.
You may want to talk a little bit about neoadjuvant and adjuvant therapy then, if we're going down that route.
Can I ask one question before you, Christine, jump to the neoadjuvant, because I think, again, very important. You talked about screening. We talked about the genetic testing. But then you also made mention about that really important part that, John even brought up about having a care team. It takes a village, right? We've talked about that a lot. Patients, many times, and we've all had friends and relatives that have all been diagnosed with cancer, they have this fear, I'm going to call it a fear, or they don't want to overburden their clinician with questions, and they don't want to feel like I'm bothering them. When is the right time to ask? But yet they're very overwhelmed. Can you just quickly kind of share some tips about what they should ask, when they should ask?
I think that it's an important piece, right? We jumped from like screening, pre-screening, pre-diagnosis, right to treatment, but there's that whole diagnosis piece in the middle, and that is huge. I'm going to call it a bit of a spaghetti breakfast right now in terms of workup and management, quite disparate in terms of what people experience depending on where they are on planet Earth. And certainly where they are even, within my own province right now in British Columbia. And I can appreciate there's a lot of anxiety, there's a lot of angst. And, it breaks my heart to think that people are worried about being a burden, and yet also breaks my heart because I really wish I could be there with everyone and hold their hand right along with them and go through the whole journey with them. But unfortunately, there's not enough hours in the day. There's not enough humans that can actually help you with that. But what there's an ability to share information and, open back the velvet curtain or what have you, right? And, share with you what the ideal pathway of care is so that you can be informed and know what to expect in terms of the next steps. When a person is found to have an abnormality within their breast, right? Let's say screening mammogram, or you feel something yourself, or the family doctor picked up something on physical exam. The next step is what's called a diagnostic imaging intervention, right? Something like a diagnostic mammogram and mammogram plus ultrasound to help further characterize what is this abnormality that we're noticing within the breast. Is it a cyst, or is it a lump that does require a biopsy to figure out if this is a cancer lump or not? And so that screening mammogram, that ultrasound can provide the information of, oh, this is a normal cyst. This is a fibroadenoma. There are certain features on the imaging that can be very helpful in terms of ruling out a malignancy. But ultimately, if it can't be ruled out completely with that extra imaging, then you would be offered a biopsy. And that biopsy involves a needle, local freezing to the skin, and then a needle that is inserted into the mass and removed to then take that tissue, look at it under the microscope, and see whether or not there are cancer cells or not. Not a super comfy procedure, not going to lie, right? The skin is frozen, but there is still some discomfort that goes along with that. Ideal time frame from an abnormality being noticed on a mammogram to actually knowing whether or not this is cancer, yes or no. There are national standards that have been put in place that kind of, the number 5 weeks is what most places are trying to work within. Is that too long? Is that not long enough? One can argue for or against that number. Ultimately, we don't know if a shorter time to diagnosis improves outcomes in terms of the stage of disease that you're diagnosed with or your length of life, right? Those correlations, we don't actually have that data yet, but we're working on it, right? Which is some of areas of research interest. So that's one thing, right? That time from abnormality to knowing if this is cancer, yes or no. 5 weeks is kind of the national standard that most places are adhering to in the country, and what is an expected duration, and more to come in terms of whether that's the right answer or not.
Okay.
After you've had that biopsy, and if we know at that point in time that this is cancer, right? At that point in time, the next step is figuring out what is the most appropriate treatment option to move on to. Is this a small tumor in the breast that we can't feel? Is this very early stage? Is this a subtype of breast cancer? Does this breast cancer have certain biomarkers that predict for very good behavior for this breast cancer? If that's the case, then likely surgery first would be the appropriate next step. Time frame between a biopsy, knowing that this is cancer, and treatment, there's a whole quagmire there. I think that it depends on the specific biomarkers that are identified on that biopsy specimen when that person has that biopsy that's assessed under the microscope.
And is there a panel that's applied in terms of the biomarkers? Is there a specific, like, we look at
Yeah, I'm
10,
so glad you asked.
20?
Yeah, so the biomarkers that are looked at, a biomarker. What is a biomarker? He's looking there, and he's like, I can see the question coming out of his brain, out of his fancy glasses. What is a biomarker? What's she on about now? And how is that different from a
Genetics.
gene? Yeah, so actually biomarkers are proteins that the tissue is expressing, proteins that your cancer cells are expressing, that tell us about how they're going to behave, whether they're going to be fast growing or slow growing types of cancer cells, and about what kind of treatments are going to be effective, right? So that's what biomarkers are. They're actually not well, they can be genes, but usually it's at the protein level when you're looking at what is being expressed by those cells. When we talk about breast cancer, there are 3 particular biomarkers that help to subclassify all breast cancer. And that is whether that breast cancer is expressing estrogen receptors meaning that those cancer cells are being fed by the human hormone estrogen, whether those breast cancer cells are expressing progesterone receptors. Ironically, not necessarily meaning that they're fed by progesterone, but meaning that they actually are even more sensitive to estrogen. HER2 proteins, what we think they do anyways, they bump into other members of their own family. They bump into other HER2 receptors on the surface of the cell or other members of their family, which could be HER3 or ERB4 or EGFR. That sends a message to the DNA of the cell telling that cell to divide, to make more, this constant signal, right? They're constantly bumping into each other and sending that message to the DNA, make more. These tend to be this subtype of breast cancer that does have a tendency to grow faster. Also, the situation where the cancer cells themselves lack all of these receptors, and the cancer is then what we call triple negative breast cancer. And that means that these cancer cells are really just on their growth signal. They are sensitive to chemotherapy. Because if someone has a hormone receptor positive breast cancer, right? If those, and we know those biomarkers based on the biopsy that's done. If someone's biopsy shows that, yes, this is breast cancer, and yes, this is the most common type of breast cancer, which is ER positive, PR positive, HER2 negative, then we know that, okay, this is actually a very well-behaved breast cancer. The likelihood of this breast cancer growing quickly is very low. The time to treatment, the ideal time to treatment, 4 weeks, 6 weeks, even up to 8 weeks from the time that you're diagnosed to having surgery or starting on some kind of treatment is probably okay, actually. That's all right.
Okay.
A bit different, we think, in the setting of triple negative breast cancer, right? These cancers that tend to be more aggressive, or HER2 positive breast cancer. Again, the subtype of breast cancers that tend to grow more quickly.
Right.
And in those types of breast cancer, we'd be aiming for a time to treatment between biopsy and starting on either chemotherapy or surgery, but time to treatment of 4 weeks would be ideal, I think, in that situation. 6 weeks, still probably very acceptable. Beyond 8 weeks, definitely, I think there is more data in the triple negative and HER2 positive subtypes of breast cancer that there might be an increase in the stage at which someone is diagnosed. Is this helpful? Is this
Oh, it's great, Christine. It's
and
been
again,
wonderful.
it's, this is what I'm talking about here is ideal, right? And if I had a magic wand and could make sure that everyone's feeling well informed, feeling well supported throughout their journey, and that these timeframes are ideally achieved, wave that magic wand right now. I'm not living in a dream world. I do know that this is not the case, and that is not the story that many people have currently. I can say that I'm personally and that our organization is working incredibly hard right now to fix that and ensure that at the very least these pathways of care, that knowing what the next steps are shared with everyone. We're working through that on the BC Cancer website to share that information. We still have a long way to go, I know.
A hot topic that's come up recently, and we talked about this, and was the whole discussion over dense breasts at the moment. I know we should have brought this up earlier, but I think women need to know a little bit about what it is if they do get diagnosed with dense breast and what it means.
So breast density, when you think about how a mammogram is completed, mammogram is taking a three-dimensional object and basically squishing it. The ability to see through that breast tissue and identify if there's areas that are concerning, if there's masses that are solid tissue that is suspicious, really depends on how dense the background tissue is. Breast density does matter in terms of being able to actually accurately find tumors at an earlier stage. Doing mammography with something called tomosynthesis, where you're actually having almost like a mini CT scan of the breast. Don't worry, it doesn't involve a whole bunch of extra maneuvers, but it can be quite helpful. mammography plus ultrasound or mammography plus MRI. Knowing if you have dense breasts is number one. So asking your doctor or reviewing your imaging report from your mammogram to see if there was any mention of heterogeneously dense breast tissue. And if there are those words, heterogeneously or homogeneously dense breast tissue may obscure the appearance of small masses. That's something I know my radiology colleagues like to say. Whenever I'm seeing that, I'm thinking to myself, okay, mammogram and something. And so mammogram and tomosynthesis or mammogram and ultrasound or mammogram and MRI. Those would be the key points to take home from that. There was some studies to suggest that people who do have dense breasts may have a higher risk of developing breast cancer. I would kind of put it back to the chicken and egg phenomenon. Do the extra imaging and be able to be confident in what we're seeing in this breast tissue. Is the risk actually higher? I don't think so. To be honest, it's an added layer of things to do on that screening side of things for people who do have dense breast tissue. Dense breast tissue is not always dense. Breast tissue evolves throughout our lifetime. We know this as girls. You start off, you don't have breast tissue. Then you do. And then over your lifetime, the density of breast tissue does decrease. So if you have dense breasts as a young woman, you won't always, sadly, have dense breasts. The density will decrease over time. Knowing what your most recent mammogram showed is very helpful.
Is there, because you mentioned mammogram plus ultrasound or mammogram plus MRI, is there a decision criteria for which one to choose?
I'm not a radiologist, so I can't speak to that, definitively. I think for each individual, there's risks, there's benefits, there's access to. I think that mammogram and is the main message to convey. Talk to your healthcare professional, whatever is available to you. To be honest with you, from the data that I've seen, mammogram and is acceptable. I think that a lot depends on your own anatomy and what's going on there.
And we have to go. That's the doorbell. All good.
We covered a lot.
We'll bring you back because we need to cover John's view adjuvant.
Yeah. Hang on a second, guys. It was Amazon guy.
It was Amazon.
Just seriously, Amazon guy. Anyways, thank you guys so much. That was lots of fun.
Thank you, Christine.
Thank you very, very much.
Take care. That was lots of fun.
Ciao, ciao.
Bye for now.
Ciao. Med Insights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. Med Insights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next Med Insights Unleashed podcast.